I am Dr. Courtney Gomez, and this is an educational video regarding the intraoperative management of the organ donor. The Scientific Registry of Transplant Recipients in the U.S. Organ Procurement and Transplantation Network put out the 30th annual data report that they provide regarding the state of organ donation in the United States. This is based on data pertaining to the period from 2009 to 2020. Donations after brain death have been steadily increasing since 2012. Potential reasons for increases in all donors is suspected to be related to the rising number of anoxic brain deaths of young people in the setting of the progressively worsening opioid epidemic. Due to this trend, there has been increasing use of organs from brain-dead organ donors. The percentage of organs recovered but not transplanted is referred to as discards. The percent discards for all organs combined in 2020 was 15% per recovered organ. There has been an increasing percentage of annual discards yearly that has persisted since 2018. Dr. Lid published a retrospective cohort study reviewing all adult and pediatric patients declared brain dead who progressed to organ donation at Harborview Medical Center between 2008 to 2019. During that time, there were approximately 105,000 deceased organ donors, with most of those organ donors being declared deceased due to brain death in the United States. At Harborview Medical Center between 2008 to 2019, 327 of these brain dead organ donors came to the operating room for anesthesia care during organ procurement. These patients were mostly male, declared brain dead secondary to traumatic brain injury, had around 3 days from the brain death declaration to the operating room, and approximately 4 organs harvested per organ donor. Of those brain dead organ donors, less than 1% received anesthesia care organ harvest. Most importantly, the average anesthesiologist saw only 1 brain dead organ donor case per year, making these cases some of the rare procedures that our anesthesiologists experience. This module will provide a basic understanding of common physiological derangements of the brain-dead organ donor and how to manage donors in the operating room for harvest. It will also review knowledge regarding common donor management goals. Soon, Dr. Lele and Dr. Suter, along with a consortium of other providers, hope to have more data to connect anesthetic management with transplant outcomes. Physiological derangements, which are induced by the process of brain death, result from the loss of integrated neurologic function and its central role in the coordination of autonomic and other basic organ functions. Secondary to a sudden increase in intracranial pressure and cerebral ischemia, we typically see hypertension and bradycardia, a part of the Cushing triad, as a last-ditch effort to maintain brain perfusion. Following this, a massive surge in catecholamines produces the phenomenon termed autonomic storming, which is characterized by marked hypertension and tachycardia as well as vasoconstriction. This produces a massive increase in myocardial work and oxygen consumption that can lead to damage in the myocardium, producing increased myocardial intracellular calcium levels that can then induce several different cardiac dysrhythmias. Following the relatively short-lived autonomic storming, there is a drastic loss of cardiovascular tone that results in diffuse vascular dilation and prominent hypotension, often requiring treatment with vasopressors and/or invasive hemodynamic monitoring. This is the most frequent complication seen in studies of brain death, topping 90% of patients. Neurogenic pulmonary edema occurs as a result of autonomic storming effects on peripheral vasculature. The marked vasoconstriction of autonomic storming leads to a shift of blood volume into capacitance vessels, producing increased venous return and right ventricular output. This results in pulmonary congestion and undue hydrostatic pressure applied to the pulmonary capillaries, ultimately leading to capillary wall disruption and leakage of protein-rich fluid and/or blood into the pulmonary interstitium. Pulmonary dysfunction from other etiologies are often present as well, such as ventilator-associated pneumonia, aspiration pneumonia, hemothoracy, and pneumothoracy, among others, depending on the etiology of brain death. Following brain death, there are also significant endocrinological changes, primarily associated with hypothalamic pituitary dysfunction. The most prominent of these changes include a high incidence of the development of central diabetes insipidus, seen in approximately 80% of brain-dead organ donors. This is produced by disruption of the blood supply to the posterior pituitary, resulting in ADH deficiency, and can result in inappropriate diuresis, severe hypovolemia, hyperosmolality, and hypernatremia. Disruption of the blood flow to the anterior lobe of the pituitary gland can lead to a significant decrease in thyroid hormone and cortisol levels. In combination with the above, this can produce an overall state of complete endocrine failure. Loss of hypothalamic control of temperature, decreased heat production from a fall in metabolic rate, the loss of muscular activity, as well as profound peripheral vascular dilation often result in hypothermia. However, a wide variation in body temperature can be seen from central dysregulation. Hyperglycemia, secondary to the stress response and peripheral insulin resistance, is often exacerbated by the administration of large volumes of glucose-containing fluids to treat hypernatremia. High-dose insulin infusion is often required to prevent hyperosmolar state. Hematologic effects of brain death are seen as a result of the initial stress response from the raised catecholamines and cortisol levels that produce a temporary hypercoagulable state, as well as a result of the disruption of the blood-brain barrier. Blood-brain barrier breakdown allows cerebral gangliosides and tissue thromboplastin to pass into systemic circulation. This results in initiation of the clotting cascade, leading to consumptive thrombocytopenia and even disseminated inflammatory coagulopathy, or DIC, in approximately 28% of brain-dead organ donors. Something which is not often discussed are the presence of spinal reflexes. These are the etiology of many muscular movements seen in the brain-dead population that could be mistaken at times for purposeful movement. Things like the Lazarus sign, where the arms are seen to spontaneously move into the air and then fall down either onto the patient's chest or back by the patient's sides. Extensor pronation movements of the upper extremities. Triple flexion reflex, where a brain-dead patient will spontaneously flex at the hip, knee, and ankle. The abdominal muscle flexion reflex, which can occur either in response to light touch of the abdominal skin or passive neck flexion, as well as periodic leg movements, can be seen at any point in time after brain death. Other physiological derangements after brain death result from decreased insulin levels that result in decreased intracellular glucose levels and therefore produce an overall energy deficit, leading to a shift towards anaerobic metabolism and often the development of metabolic acidoses. Electrolyte abnormalities are commonly seen as well, like hypernatremia, hypokalemia, hypomagnesemia, hypophosphatemia, and hypocalcemia. These are often secondary to therapies like mannitol, fluid restriction, and glucocorticoid usage, as well as secondary to diabetes insipidus. Support for the brain-dead organ donor in the ICU is managed by the ICU nurse as well as the Organ Procurement Organization's coordinator. Dr. Lele and Dr. Suter do provide consultative support for the local organization in Seattle, but usually no other direct physician involvement is present in the perioperative period. Common pharmacological interventions provided in the perioperative period for the brain-dead organ donor include things like vasopressors, primarily vasopressin followed by norepinephrine, and intermittently inotropes when vasopressor support is not enough. Endocrine-directed therapies like thyroxine infusions, vasopressin infusions to treat diabetes insipidus, insulin and D5 infusions to treat stress-induced hyperglycemia, as well as corticosteroids to help stabilize organ function are common during this time frame as well. Other common interventions include crystalloids, as tolerated for hypovolemia or low urine output, electrolyte replacement or management, diuretics for pulmonary edema, as tolerated by hypotension, as well as antibiotics as determined appropriate for treatment of things like aspiration or ventilator-associated pneumonia to prevent sepsis until organ donation. On brain death declaration, ASA physical classification status changes to what? A, ASA 1, B, ASA 2, C, ASA 3, D, ASA 4, E, ASA 5, F, ASA 6. F, ASA 6, a declared brain dead patient whose organs are being removed for donor purposes. The donor management goals outlined in a study by Patel et al. Titled "The Impact of Meeting Donor Management Goals on the Number of Organs Transplanted per Expanded Criteria Donor" have been proven to increase number of organs harvested per donor. It is expected that these criteria applied intraoperatively will also improve graft function upon transplantation. On this slide, highlighting the cardiovascular and pulmonary donor management goals, the following goals were seen in the study by Patel et al. To improve harvest. Mean arterial pressure from 60 to 110 millimeters of mercury, central venous pressure, if being monitored, from 4 to 12 millimeters of mercury, load dose or number of vasopressors less than or equal to 1, left ventricular ejection fraction greater than or equal to 50%, and P to F ratio greater than 300. Other accepted donor management goals from evidence found in literature included on this slide are the following. Tidal volume 6 to 8 milliliters per kilogram of ideal body weight, lowest FiO2 to main PaO2 of 80 to 100, or FiO2 less than 40%. On this slide, highlighting the renal and endocrine donor management goals, the following were proven to increase the number of organs obtained per expanded criteria donor per Patella et al.'s paper in 2016. Sodium level less than or equal to 155 milliequivalents per liter, glucose less than or equal to 180 milligrams per deciliter, urine output greater than or equal to 0.5 milliliters per kilogram per hour, and arterial pH of 7.3 to 7.5. Other accepted donor management goals from evidence within the literature included on this slide are normothermia and urine output less than or equal to 7 milliliters per kilogram per hour. Adherence to these donor management goals intraoperatively is relatively well followed at Harborview Medical Center. According to Dr. Laley's evaluation of the Harborview medical experience with organ donors, there is always room for improvement. Common procedures performed by anesthesiologists during organ procurement procedures include invasive hemodynamic monitoring through the commonly already present central venous access and arterial lines. Peripheral IV access may need to be assessed and replaced depending on needs for fluid boluses during the case. Valsalva maneuvers or breath holds are common during lung procurement, as are bronchoscopies to evaluate and lavage the lungs prior to harvest. Repeated arterial blood draws to assess arterial pH, blood glucose, and electrolytes are performed in almost every case. Common pharmacological interventions provided by anesthesiologists and anesthetists during organ procurement procedures include muscle relaxation to prevent spinal reflexes from interfering with the procurement. For hypertension intraoperatively, the agents of choice are volatile anesthetics and short-acting calcium channel blockers. Opioids and beta blockers are generally not used as they have not been found to have favorable effects on hemodynamics. For hypotension intraoperatively, the agents of choice are vasopressors, most commonly vasopressin, followed by norepinephrine and epinephrine based on data review, and intermittently use of inotropic support such as dopamine or dopamine needs to be added. For lower urine output, anesthesiologists and anesthetists often utilize crystalloids during organ procurement procedures. However, they must be careful of excessive use depending on the organs being harvested, particularly avoiding excessive dependence on crystalloids when lung harvest will be performed. Occasionally, administration of antibiotics via indwelling nasogastric or orogastric tubes are provided in the setting of pancreas procurement for transplant. Anesthesiologists typically need to continue treatment for endocrinological failure, such as thyroxine and or vasopressin infusions, to avoid this causing further hemodynamic instability during the case. Insulin infusions are also continued and managed according to the local insulin protocol. The procedure will end for the anesthesiologist at the time when aortic cross-clamping is performed. Prior to this, a large intravenous bolus of heparin will be provided through a rapid-flowing peripheral or central venous access at the direction of the surgical team. Once cross-clamping has occurred, then the anesthesiologist stops all infusions and closes the case while the surgical team continues to harvest. At what point does the anesthesia portion of a brain-dead organ donor organ procurement case end? A, after the beginning of organ harvest. B, after aortic cross-clamping and cessation of all infusions. C, once the surgeon is done closing. D, when the donor leaves the OR. B, after aortic cross-clamping and cessation of all infusions are confirmed, anesthesia machine and monitors are turned off. We hope that you feel we have met the educational objectives we set forth to at the beginning of this module. Please stay tuned to the future research coming out in the arena of brain-dead organ donation, intraoperative management, and its effects on graft function and outcomes in transplant recipients. Thank you for your time and attention. You may now move on to the post-test quiz. Please do not forget to rate this module on the follow-up survey.